Welcome, everyone. This is not bad considering one where we were last year, and then all the uncertainty over just the last month or two. So, is this for me?
Yes, it is.
Oh, Chelsea says, please ask people to sign in. Oh, there's a sign-in sheet. You can make this announcement, Chelsea. It's just us here, friends and family. Programs available as well. And I can walk around and pass out if anyone needs one. If anyone needs a program, Chelsea will get up and walk around and pass it. Go up for yourself and get it if you need one. Great. All right. So you guys know what this portion is. We'll have more to say about different people that we need to acknowledge. One, when we really start our formal program this afternoon at 1, and then certainly tomorrow evening. But this is all Dr. Jameson's baby, and as you know, it has really elevated in terms of quality and formality, and it doesn't happen automatically. So a huge amount of work from you guys. So hats off. So all you can drink tonight from 5 to 7 at Boylan. So feel free. Actually, I do hope you come in. It's open to everybody. Because normally our banquet, as you know, well, not all of you do know, but normally the banquet is 125 people and all the nurses come and our support staff. So we couldn't do that this time. So that's what we're trying to do from 5 to 7, just an opportunity to say hello and spend some time with them. So with that, I'm going to turn it over to Mark and Dr. Jameson, and he will lead us. Thanks for setting all this up, Mark. Really appreciate it.
All right, good morning. Wow. I'm not sure what to say after all this time. We're back. Yeah, so I'm not sure what to say, so I won't say anything. That may be a first, but okay. I do want to start off by saying thank you for all of the hard work from residents, a lot of unsung work by medical students, other folks, Andrew, of course, and others that are involved in these projects. These always turn out to be great. And looking at the abstracts this year is not an exception. So we would ideally like to kind of limit the presentations to about 10 minutes. Give or take. We do have a little buffer, so if you take a little longer, it's not the end of the world, but ideally we'd like to have a couple of minutes for questions after each presentation, and during that time we'll switch the presentation over, but we can kind of dialogue about anything that comes up from the talk. We have kind of grouped these into, or I have kind of grouped them loosely into kind of basic translational applied population types of science in the first section, and then sort of more pure clinical science in the afternoon. It won't take that long in the second part. And so without further ado, then we'll get started. Dr. Jonas is going to start us off. Her title is Using CRISPR to Create HA Tag Knock-in Mouse to Localize ATP 8B1 in the hair cells stereocilia subdomains. Just one other thing. If you are a faculty member and you do not have a judging packet, can you show me your hand? Okay, great, thanks.
Okay, good morning. I feel like I was probably just up here 2 days ago. I was just up here 2 days ago giving a presentation, so poorly timed. But my topic this time is going to be very different from what I presented on Wednesday. The title, like Dr. Jameson said, is Using CRISPR to Create an HA-tagged knock-in mouse line to create ATP8B1, or to localize ATP8B1 in hair cells stereocilia subdomains. Oh, okay. Okay, so first, just a little bit of background as to the hair cell stereocilia. So hair cells stereocilia are on the apical surface of hair cells, and they're composed of actin filaments, and then they're covered with a lipid bilayer. And they contain mechanically gated conduction channels. When these conduction channels open, cations enter, and then the membrane potential increases, and that causes calcium to leave the cell, eventually causing exocytosis of glutamate and eventually creating neural signals. Like I said, the stereocilia is composed of actin filaments and it's covered with a lipid bilayer. And the membrane asymmetry of this lipid bilayer is really important. We know that the lipid bilayer, the inner leaflet and the outer leaflet have a different composition. And this is maintained by some proteins called flipases, flopases, and scramblases. Dr. Shin, my mentor, was really interested in a flipase called ATP8B1. And what this does is it takes lipids that are on the outer membrane and puts them into the inner membrane. And how he got interested in this and how really is because of a rare disease called benign recurrent intrahepatic cholecystitis. And it is a mutation in the flipase ATP8B1. The phenotype of this disease is jaundice and hearing loss. Prior studies are few that look at this topic, but they have shown that ATP8B1 is essential for maintaining normal hearing and that it is located on the hair cells. This is a study that shows just that a mutant mice with the ATP8B1 protein knocked out, the mice have hearing loss. This is some unpublished data from some collaborators of Dr. Shin, basically looking at the RNA within the cells and saying that the RNA shows that the RNA for the protein is within the hair cells. And specifically up here, up there, you can actually see that they are on the outer hair cells. But going from RNA to DNA to protein is really lots of steps. And we were really interested in the protein, not RNA. So we had this hypothesis that ATP8B1 establishes a specialized stereocilia lipid environment required for hair cell mechanotransduction and stereocilia formation. And the maintenance and survival, without that, there would be hearing loss. So there are many parts of the research plan, but this is just one part. First, we wanted to determine the location of the ATP8B1 in the hair cell's stereocilia subdomains. And our plan for that was to harvest the cochlea and then perform immunofluorescence experiments to localize the protein using various anti-ATP8B1 antibodies. And if it was not successful, we were going to use CRISPR to generate a mouse line in which an HA tag was knocked into the genome. And then again, we're going to harvest the cochlea and perform immunofluorescence experiments on that. As you can probably tell from the title, it was not successful with just using antibodies against ATP8B1. So we did make a CRISPR model with an HA tag knocked into the genome. I want to talk a little bit about CRISPR and what an HA tag is first. So HA tag is actually the surface protein of the flu that makes it infective. And a lot of studies have shown that there is a very specific antibody for this protein, and you can localize other proteins if you have an HA tag put into the genome, kind of depicted in this schematic. CRISPR is how the HA tag is specifically knocked in. And it's actually pretty simple. You get a Cas9 protein, which is known to cut up genomes, and you make a cut in the DNA, and then you create a repair template. And the first part of the repair template is homologous to the DNA of the genome itself. The second part is what you want to add in. So the repair protein for the genome is just chugging along, repairing, and then it gets to what you want to add in, and it just keeps on repairing and adds it in. So we added this to the N terminus, so at the beginning of the genome. And why we added this to the N terminus is because the HA tag needed to either be at the N terminus or the C terminus so that the tag itself did not disrupt the protein function. But sometimes CRISPR doesn't work every time. It works probably 50% of the time. And when it doesn't work, after where the break is made, the genome just kind of pushes itself back together, and that makes a knockout gene. And we actually wanted a knockout gene as well, because that could establish a loss of function within the protein. If we had put the CRISPR at the C terminus, so at the end, the DNA would have completely been translated, and then it would get to a defect at the end, but most of the amino acids would have already correctly been translated, and it would be less likely that there would actually be a loss of function if we put it at the C terminus. So our CRISPR outcomes were really great. You can see this is a PCR with amplification of just a portion of the genome. The black wild type is right here. And above that, if any bands above that are knock-in mice, because PCR kind of separates things by size, so it doesn't move as far if it's bigger. And anything below that is a knockout mouse. So we were really lucky, actually, and we got 2 homozygous knock-ins that were male and female. So we were actually able to start breeding pretty quickly, which was really wonderful. So once we breeded them, we have these mice that have a tag knocked into them. We then used a scanning confocal microscope to localize exactly where the ATP8B1 protein was on the stereocilia. And this is a scanning, or not a scanning, confocal microscopy of the hair cells themselves. You can see these lower ones are the outer hair cells, and the upper ones are actually the inner hair cells. And this is at 63 times magnification. The green is the actin. That is our control, just saying these are stereocilia. The red was our antibody against the HA tag. And you can see actually that we do not localize the ATP8B1 onto the stereocilia. Yes, there is red up there, but it's very non-specific and likely related to not washing the cells well enough. We were expecting or hoping that we would see little red dots on, we were hoping that we would see little red dots on the stereocilia themselves, saying like, this is where the protein is. If we compare it to the wild type, again, the lower ones are the outer hair cells, and then the inner hair cells, you see no difference between the wild type and the mice that had the HA tag knocked into them. So then we started asking, why was there no localization? We know that this is a really great antibody. And we did a couple of experiments, or had a couple of hypotheses as to why there was no localization. And we ruled out the first 2. And so then we came to the question, is it because there was an issue with the tag? Could possibly the N-terminal HA tag be cleaved off after translation? We know it's in the DNA. We did the PCR, it's there, but after translation of the protein, could potentially it be cleaved off? So to look at this, we performed a Western blot, which separates proteins based on size. And we used a mouse liver to do this of our knocked in and our wild type mice. And it was great that we used the liver, because to do a Western blot, you have to homogenize a large amount of tissue, and the cochlea is very small, and we couldn't homogenize it unless we had like 500 mice. But the liver, because we know that the liver with this benign recurrent cholestasis, the liver also has this protein. So we were able to perform the Western blot on the liver. So these are the 2 options of what we could get. Because a Western blot separates proteins by size, the HA tag is adding size to the protein. And so it would be bigger. So we would see a band. We would see a band that is higher up compared to the wild type. So the wild type, the protein would move down the strip. The HA tag, it would move down as well, but it wouldn't move down as quickly because it was bigger. If the protein was cleaved off, we would see 2 bands. The wild type and our CRISPR generated mouse would have bands at the same location. And this is one of the Western blots that I performed. And you can see that there are 2 bands at the same location, indicating that the HA tag that we had CRISPR'd into the genome had been cleaved out. This is another Western blot. The first one used the ATP8B1 antibody. We also used an HA antibody, and you can see that there are no bands at all because the HA antibody had nothing to bind to. So in conclusion, the HA ATP8B1N mouse was successfully generated via CRISPR with a normal ABR of the founder mouse, but we were unable to localize the protein using confocal microscopy. And that was because the mouse had cleaved out the HA tag after translation of the protein. So that is the end of my presentation. Just a few thank yous. Obviously, Dr. Shin helped me a ton with this, as well as his postdocs. Jeff Casaza was in the lab with me at the same time, and he was really a sounding ground before I presented my data at lab meetings and kind of was troubleshooting. He was my sounding ground for, hey, why do you think this is going on? So thank you to Jeff as well. Any questions?
Zoom in. If you have a question, please raise your hand. I'll come to you with the microphone.
Oh, there was a microphone. Yeah, no. Okay, great.
Project I've been involved with since working in the with Dr. Gennaro in his lab. For the sake of time, I'll cruise through the background slides so that we can stay on track. As you know, glottic insufficiency is the pathologic incomplete closure of the true vocal folds during phonation or swallowing. There are a diverse assortment of etiologies as listed, and the presentation of dysphonia and dysphagia can be severe enough to cause recurrent pneumonias and devastate quality of life. Treatment of glottic incompetence at its basis is to correct the incomplete closure. In general, there are a few main approaches. We have laryngeal framework surgery, laryngeal reinnervation surgery, and injection augmentation. These approaches have their own overarching pros and cons. While delving into these treatment modalities is also probably a bit too much for the scope of this brief talk, the take-home point here is that each of these treatment modalities have their own inherent limitations, which has fueled the need for further research surrounding the treatment of this disease. We have found that experimental laryngeal models utilizing rabbits have several benefits, including anatomic similarities and translational ability to facilitate surgical procedures. The rabbit has a larynx about the size of a pediatric patient, so there's a lot of overlap with what the instruments we can use. To date, recurrent laryngeal nerve sacrifice models have been used to study vocal fold paralysis. However, this strategy carries notable drawbacks, such as the need for detailed microsurgery. It requires months of time post-operatively where you have to maintain the rabbits and allow for subsequent vocalis muscle atrophy and glottic insufficiency to develop. Allowing for this increased risk for post-operative complications affecting sample sizes and the guaranteed housing costs, as well as anesthesia required for a second phonation procedure after all of that. Another intriguing methodology developed in rabbits is to evaluate for in vivo phonation, described by Ji and associates, who demonstrated vocal fold medialization with bilateral cricothyroid muscle stimulation. So in order to accelerate research timelines, reduce costs and complexity of an in vivo model, and decrease the risk associated with multiple animal procedures, our ultimate goal was to develop a novel in vivo model for glottic insufficiency by simulating a reduced unilateral vocal fold mobility with phonation, or essentially a vocal fold paresis or paralysis. Ultimately, this model needs to have a reproducible methodology. It has to generate reliable, measurable data, and be cost effective in order to incentivize future research projects and help advance our understanding of the treatment of glottic insufficiency. This project was pre-approved by the UVA Animal Care and Use Committee to limit the burden of animals required. This project, our 7 rabbit subjects were able to be utilized as their own controls, so the case and controls. Our procedure was relatively simple in the grand scheme. After anesthesia, 2 tracheostomies were made, one distal to the lungs, so we can ventilate and administer inhaled anesthesia to the rabbit, one proximal to serve as a means to phonate the glottis through retrograde humidified airflow. Next, the cricothyroid muscles were isolated bilaterally. As you know, they're relatively easy to find, easier than a recurrent laryngeal nerve. And a pulse stimulator was used to deliver bipolar stimulus to these muscles for 3 seconds on, followed by 3 seconds off. The control scenario was simulated with bilateral cricothyroid stimulation. So the case rabbits or phonations were simulated by only stimulating the right cricothyroid muscle, theoretically resulting in a reduced left vocal fold mobility. To obtain objective data, the larynx was suspended with a modified pediatric Parsons laryngoscope and mounted with a rigid endoscope capable of 5,000 frames per second videos. And we also obtained audio data. Analysis of the captured images was performed for 5 consecutive phonation cycles that were reproducible and representative of the entire trial. For each cycle assessed, the frame with the maximal glottic opening was selected for measurement. Measurements were made including maximal glottic area, right amplitude, left amplitude, and glottic length. By dividing the maximum glottic area and the amplitudes by glottic length, we're able to effectively standardize the values to account for subtle variations in camera angle and slight anatomic variations between the rabbits. Additionally, we could calculate the pitch frequency for each cycle by dividing the known 5,000 frames per second by the number of frames per cycle, which we could count. Lastly, our voice analyst software was obtained to record a recorded frequency as well as max sound intensity for each phonation. The image and audio values obtained for each of these 5 cycles were then averaged for each rabbit and across rabbits for unilateral and then bilateral stimulation respectively, and paired t-tests were then run for the following results. Before I go any further, I'd like to quickly debrief on how to read these pretty awesome violin graphs. They're probably a little bit fancier than they need to be, but this bold line is the mean, and then these dashed lines are the confidence intervals. So any overlap means it would be insignificant finding, or at least greater than 0.05. But if they're separate, then we have our significance. Mean glottic area was measured in order to demonstrate a larger glottic gap in the glottic insufficiency group. Therefore, we expected the unilateral mean glottic area to be greater than the bilateral. In fact, the unilateral group had a pretty significant, definitely significant difference, and it was greater than the bilateral group, and this confirmed our hypothesis. The left amplitude was then measured to compare the laxity between the stimulated and unstimulated left true vocal fold. Therefore, we expected the unilateral left amplitude to be greater than the bilateral group. While we did not achieve significance, our results did trend as expected with greater amplitude in the unilateral group with a p-value of 0.059. And I meant to mention this earlier. One of our 7 rabbits did have an intraoperative hematoma and had to be excluded from the results. So this was with basically an N of 6 that we almost achieved significance here. The right amplitude was measured as a control since the right vocal cord was stimulated in both settings. So we didn't expect a difference between the two, which we confirmed with our analysis. These were insignificantly different. Next, we wanted to assess our pitch or frequency data. We wanted to prove that our method of calculating frequency was comparable to recorded frequency. So in order to do this, we analyzed calculated versus recorded for the unilateral group and as well as the bilateral group. So first, we compared the 2 unilateral groups here, and there was no significant difference between calculated and recorded frequency. And then we compared the bilateral group and we didn't find a difference either. So this helped reassure that this method of objective calculation of frequency was adequate. Now that we verified that we could use the calculated frequency, we hypothesized that the unilateral stimulated rabbits would have a lower pitch than the bilateral rabbits. And we did in fact see these differences with another significant difference in pitch frequency. And lastly, we examined max sound intensity between the groups. And similarly, we hypothesized that the glottic insufficiency group would have a lower phonation volume due to incomplete closure, and which we again confirmed with our data. So just kind of to wrap things up, we wanted to create a model with reproducible methodology that could obtain reliable, measurable data, be cost effective, and in order to incentivize future research. We believed we achieved this with our task of this study, and our methods reveal a model requiring only a single operative procedure without the need for prolonged housing costs, and one in which each rabbit could serve as both its case and control. And lastly, our data was supportive in suggesting that unilateral cricothyroid stimulation in these rabbit sessions simulated glottic insufficiency effectively. And all hypotheses that we had were confirmed, with the exception of the left vocal fold amplitude, which again approached and trended towards significance with an N of only 6. Ultimately, this novel model will provide a pathway for future cost-effective studies and better understand glottic insufficiency with the development of novel treatment modalities. There's undoubtedly a role for new injectable treatments on the horizon, with advances being made in biomaterials. And I can firsthand speak to the development of the MAP hydrogel filler that we're testing in the Dinero Griffin lab that provides hope for a permanent and reversible vocal fold injectable for glottic insufficiency. And using a methodology like ours that I've talked about today can help get us one step closer to mainstream production. Lastly, our method of cricothyroid stimulation is a means of objectively measuring glottic function through mean glottic area, amplitude, frequency, and sound intensity could also be translated into research looking at other glottic insufficiency etiologies such as laryngeal trauma and PGS, or post-glottic stenosis. With the limitations and costly nature of animal research, we have opened a door to bring efficiency and progress to a historically time-consuming component of medical research. I'd like to thank those who helped me make this project possible. The research was supported by the Coulter Foundation Translational Research Partnership Award. I'd like to thank the team of past and present. As you see, Heather Kane helped lay the foundation for some initial rabbit studies along this pathway, and now a Dr. Bill Swift carried it home most recently. Lisa and Patrick were also critical for the roles in rabbit anesthesia care and housing within the lab. And last but not least, Dr. Dinero was the leader of the project and has been one of a kind mentor through this process. Thank you, and I'll take any questions. Dr. H.
Do we need you to talk into a microphone?
Bilateral and the unilateral. Was there a reason for that?
That's a good question. And actually, I may have to defer to Dr. Dinero for the reason behind that specifically. Do you have an answer for that?
There you go. Thank you.
Sure. So the question was, we use different stimulation intensity, different amperage for the unilateral versus bilateral. And we did that because the way we set up unilateral and bilateral was it was in series rather than parallel. So they were daisy chained electrodes. So we have that to have the same amount of stimulation per vocal fold.
So Ian, I have a question. I think an important question, and that is, what is your emotional response to hearing a rabbit scream?
Speechless, and emotionless. You have to block it out.
Got to block it out.
Yeah.
All right. You know what they say, warm hands, cold heart. All right, Dr. Bazzi's up next. She's going to talk about the effects of emu oil and statins on sinonasal symptoms and quality of life in patients with refractory chronic rhinosinusitis. And this is an update from her research block.
All right, good morning. I don't probably need this microphone. So for my presentation this morning, I'm going to be providing an update on my research block where I worked on developing 2 projects, which aim to identify the effects of emu oil and statins on sinonasal symptoms and quality of life in patients with refractory CRS. So the overarching objective of both of my projects were to study the role of novel therapy in patients with CRS refractory to standard topical and systemic medical treatment. The novel therapies we introduced were emu oil and statin medications. Our primary endpoint was to evaluate patient-reported outcome measures and quality of life with the SNOT-22 questionnaire. And the secondary endpoint was to objectively evaluate the sinonasal cavities via rigid endoscopy and the Lund-Kennedy scoring system. Before diving into each one of my projects, I just want to provide an overview, and I'll refer back to this slide throughout my presentation. So my overall research block goal was to determine the utility of these novel therapies in patients with refractory CRS, with those specific novel therapies being the emu oil and statin drugs. And as my research block projects are more focused on the clinical aspects of these novel therapies, I had the really unique opportunity during my research block to understand the breadth of clinical trial research. The emu oil project was to be a phase 1 to phase 2 study. During my research block, the goal was to submit an investigational new drug protocol, which I'll talk about shortly, and then initiate the study. The statin study was to be a phase 2 study. The goal here was to develop and submit a core grant for this project by the end of my research block. Briefly, the main differences between phase 1 and phase 2 trials have to do with the goal to be achieved in that phase. Phase 1 trials test the safety and tolerability of a drug. Phase 2 trials further assess safety, but are more so testing the efficacy of a drug. And then, so very quickly, just some background. CRS is a common and debilitating condition that affects 10 to 15% of the population, and is one of the most common chronic conditions in North America, has very significant socioeconomic implications in terms of how much is spent annually, about $8.3 billion on prescription drugs, office-based care. Surgery for CRS is performed over 250,000 times annually, and the indirect costs are also consequential, 1 to 2 lost workdays per patient per year. The American Academy of Otolaryngology diagnostic criteria for CRS, I won't go into that this morning, but can be found online under the Academy's clinical practice guideline. And I'll just touch on refractory CRS for a second, because that was sort of the patient population that we are looking at specifically for our projects. And this term describes CRS that is unresponsive to medical and surgical therapy. So individuals with refractory sinusitis have persistent signs and symptoms of CRS despite medical therapy and technically adequate endoscopic sinus surgery. The arsenal of available therapeutic modalities has increased over time. We have things like baby shampoo, xylitol that we can use. And while a lot of these are overall well tolerated and cost effective, patients are often refractory to these therapies and are left with a few other available alternatives, thus the birth of my projects. So first, I'll discuss the statin trial, which is, like I mentioned, a phase 2 trial. It was to be a placebo-controlled, blinded, randomized control trial. And our goal was to study whether statins can be a novel therapy in this patient population. So just very quickly, the catalyst for this project was derived from a recent paper published by our very own rhinology team here and Dr. Chernin here at UVA, which found an association between statin use and decreased prevalence of CRS in a nationally representative sample of outpatient visits in the United States. As we all know, statins are inhibitors of the rate-limiting enzyme HMG-CoA reductase and cholesterol biosynthesis. And research suggests that statins may have anti-inflammatory effects via modulation of lipid-containing enzymes and mediators, and therefore may have clinical utility in the treatment of CRS. In an in vitro study to determine if statins induce anti-inflammatory effects in upper airway inflammation, sinus tissues were collected from patients with CRS and found that the expression of inflammatory mediators, highlighted by the arrows here, which came out of Stanford, showed that the inflammatory mediators were suppressed in patients on statins. The same study also induced inflammation on primary nasal epithelial cells using airborne particulate matter and found that those cells pre-treated with statins block the expression of those inflammatory mediators. So overall, there's growing evidence that statins possess potent anti-inflammatory properties, and so sort of catalyzed our project moving forward. So one of the major outcomes of my research block was establishing this clinical trial protocol for the study and submitting it for a core grant. So for this study, we primarily hypothesized that patients who utilize statin medications will have improvement in their endoscopy and SNOT-22 scores. In terms of recruitment strategy, patients will be recruited from our department, as well as from the Ear, Nose, and Throat and Facial Plastic Surgery Center of Fredericksburg, which is a private practice group with whom we have established previously collaborative efforts and work with them very frequently. At UVA, a cohort builder such as Slicer Dicer will be utilized to identify subjects meeting our inclusion criteria for this study. And at the private practice clinic, patients will be recruited by the otolaryngology physicians in a high volume setting. Study-related flyers will also be posted in clinic waiting rooms at both locations to ascertain interest in patients. Inclusion criteria for CRS patients will be based on the Academy's guidelines, and then we'll only include those patients that are between the ages of 18 and 70 years old that have refractory CRS, patients that are currently on systemic corticosteroid therapy, and those already on statin medications will be excluded from the study. In addition, subjects who are pregnant or those who have active hepatic disease or unexplained persistent elevations in aminotransferase will be excluded. At initial visit, a history and physical are sufficient to confirm that patient meets eligibility. All patients will obtain a pretrial lipid panel blood level to assess for their LDL. This lab will also serve as a marker of compliance, as we expect that post-trial lipid panels will be lower in those that were in the intervention group. In terms of a safety monitoring plan, an independent data and safety monitoring board will consist of principal investigator Dr. Matos and consulting UVA cardiologist Dr. Christopher Rembold, who has graciously agreed to serve as a collaborator for our study. All drugs will be prepared by the UVA investigational pharmacy, who we have been working very closely with. And after discussion with Dr. Rembold, decision was made to use rosuvastatin 10 milligrams for the treatment arm. As I mentioned previously, this is going to be a randomized trial with 2 arms, and patients will be randomized within a 1-to-1 ratio between the rosuvastatin intervention arm and the placebo arm. Our goal is to recruit 84 patients total, and this sample size was calculated based on a prior study, which had recommended a minimal clinically important difference of 12 for SNOT-22 scores of CRS patients undergoing medical management. So in collaboration with the UVA Department of Pharmacy's investigational drug service staff, a fixed randomization scheme will be utilized. Eligible patients will be randomly assigned to the investigational package or the placebo package at a 1-to-1 ratio, and our investigational pharmacy will be the ones that will prepare these packages for them. Follow-up for the interventional phase of the study will be conducted with the clinic visit at 6 weeks for a history and physical, and a final interventional phase clinic visit at 3 months. Subjects will then undergo a 1-month washout period. So during this washout period, all the subjects will return their medications, and we will have those that are in the statin treatment arm undergo a liver function test lab, as well as a post-intervention LDL level. Final assessments will occur at 6 weeks and 3 months from the end of the washout period for a full history and physical. SNOT-22 will be obtained at each clinic visit, and de-identified photo documentation of sinonasal endoscopy will be obtained at each clinic visit. The endoscopies will be independently and blindly reviewed, thanks to Dr. Payne and Dr. Matos, and endoscopy scores will be assigned. For the endoscopies that are going to be performed at our private practice clinic, the images will be brought to UVA by research personnel for evaluation by our UVA rhinologists. The final study clinic in total occurs 7 months from the initiation of the study, and after all of the data has been collected, we will perform our appropriate data analysis. So that was talking about the statin study. And so my research block had 2 projects. So now I'm going to move on to my emu oil study. So why emu oil? But honestly, the better question is why not emu oil? So emu oil has been studied extensively in numerous fields of medicine and shown not only clinical efficacy, but also safety. I think I'm running a little bit over time. So it has been studied in multiple fields already. And so based on this, we sort of have determined that it is a safe product to use. It's been used in various industries. So the emu oil study was to be a pilot prospective open label trial, and it's very similar in outline to the statin study. Because it's a phase 1 trial, we would only need up to 15 subjects meeting inclusion criteria to be recruited. And the emu oil will be administered via dropper into the nasal cavity. We would then perform weekly telephone calls for documentation of safety and adverse effects, with clinic visits at 6 weeks and final follow-up visit in 3 months for final history and physical. So a major portion of our research block was actually submitting a 50-page investigational new drug protocol with the assistance of the clinical trials office. And the reason I needed to submit an IND for this project and not for the other project is because emu oil is an unapproved drug per the FDA. So just really briefly, federal law prohibits the distribution of any new drugs or biologics until the FDA has reviewed the clinical data and determined that a particular product is safe and effective for specific use in human subjects. So in order to test a new drug, it is necessary to obtain an exemption from this law. And whether an IND is needed to conduct a clinical investigation of a drug primarily depends on the intent of the investigation and the degree of risk associated with the use of the drug. Specifically for emu oil, an IND is needed as it is a newly developed drug, not approved by the FDA, and is going to be tested for safety and efficacy in human subjects. And then once the IND has been submitted, the FDA has about 30 days to get back to you about the IND application so that you can incorporate your changes and then resend it into them for further approval. So one of the many aspects of starting a clinical project, as I learned throughout my research block, is learning to manage expectations regarding a timeline. And that was definitely true in regards to submitting at least this IND. I was ready to submit it pretty early along in my research time, but it was unfortunately not formally submitted until early January of this year, which was towards the end of my research block. And in terms of the FDA's response to our study, they did respond to our proposal. And unfortunately, we're not willing to approve the emu oil for use in humans directly, yet as they deemed that there was inadequate non-clinical or clinical data to support the daily administration of emu oil into the nasal cavities. Then they provided additional recommendations, and they requested that if we do move forward, that we either perform animal studies or histopathological studies. But thankfully, Dr. Barker teamed up with Dr. Matos and Dr. Borish and developed a research block project that she is currently executing that will hopefully achieve the FDA's recommendation, where she will be studying the effects of emu oil on the gene expression of known cytokines and chemokines associated with type 2 inflammation compared with effects of steroids and negative controls. So in summary, my overall research block goals were to determine the utility of novel therapies in patient refractory CRS. I was successfully able to submit the IND for the emu oil. However, the implementation of my phase 1 trial was not possible as the FDA requested further research to be done. So thanks to Dr. Boris and Dr. Matos, Dr. Barker for keeping the emu oil dreams alive. The statin study protocol was established with the appropriate collaborators, culminating with my submission of a core grant, the outcomes of which are still pending. So thank you, everyone. And thank you to Dr. Matos, Dr. Waycamp, Andrew, for all your help throughout my block. And of course to RRC for allowing me to pursue a somewhat atypical research block project, but allowed me to gain significant insight, albeit just a taste into the world of clinical trials. So I will take any questions. People do everything with emu oil. I'm sorry. Oh, repeat. Oh, the question was, I don't need to do that. What do people do with emu oil? It is available for topical and for like PO intake. So people take it orally just now. You can buy it on Google, on Amazon. But people also more so commonly put it on topically. It's used as a barrier cream for newborns. It's used in the cosmetic industry for under eye wrinkles and dark circles. And mostly it's been studied in mouse models and in the GI system is where most of the studies have happened so far, but it's pretty frequently used, I would say. There are a lot of formulations out there. Wrinkles, yeah.
Anisha, I have a question.
Yeah.
If you look into the future, if assuming that the the statins prove to have benefit, how do you envision them being used for these patients for short bursts or for long-term treatment? And what do you think the medical implications of that are?
Sure. So I think one of the reasons that we decided to even use statins was because they have a low side effect profile and can be very cost effective. And so I can see these being a long-term therapy for these patients with CRS, which is already a chronic condition. So as a long-term therapy, what was the second part of your question?
Just about medical
Yeah.
patients, obviously, concerned
Yeah.
about liver side effects
Right.
and, recurrent labs and all those.
Right. And so that's why we actually have Dr. Rembold on board, because normally ENT doctors are not the ones prescribing statins. But because of the low side effect profile and rosuvastatin having been very well studied, I think the quoted data is already really low. There's a low percentage of myopathy and liver enzymes elevating. And so I think it could actually be a very well tolerated medication in the long term. Yeah.
Thanks.
Yeah. Thank you.
All right. Next up is Dr. Iorio. She's going to talk about Bell's palsy, seeking the answers in social media.
So I think that my talk was strategically placed amongst all the basic science because we're really going to change gears here. So my project is Bell's palsy, seeking the answers in social media. This was done with the help of Dr. Oyer and Dr. Wykamp, which we've heard that she's been highly involved in all of our projects. So a little bit of background for certain people in the room. If you don't know what social media is, it is essentially socializing on the line. It's using the internet to interact with people around the world any time of the day, with people next door, people in this room, or at any time, 24 hours a day. The number of people that use social media platforms has dramatically increased over time. Use of social networking sites from 5% in 2005 to now up to 50% in 2011, and it is exponentially growing over time. What are social media sites? What am I referring to? That's Facebook, YouTube, Twitter, WhatsApp, Snapchat, MySpace, all of those sorts of things are considered social media platforms. It's been utilized in businesses because they know that that's where customers are and that's how to get their attention, and it's efficient, easy. You can get a targeted message across. But it hasn't really been used well in the healthcare setting until recent years. So industries such as retail and hospitality quickly saw the potential in utilizing social media, but the health sector has been slower to move into this realm of marketing, because that's basically what it is utilizing social media, what people look at, they spend their time looking at it and then getting a point across. Marketing companies have dramatically increased over time just for this, just for using ads to get people's attention and seek out care. One of PricewaterhouseCoopers did a study that showed that 42% of Americans search for health-related information on social media platforms. So people used to just use it for ads for selling and shopping online, but now people are actually seeking out health problems on social media platforms. And close to half of those consumers use the social media health information to influence their decision to seek care, which was a high number, more than I would have anticipated. So we use Twitter. Twitter is one of these social media platforms. It's pretty well known, especially in the political realm over the last 8 years. But it's so technically speaking, it's a microblogging system that allows you to send and receive short posts, which are called tweets. Tweets are up to 140 characters long, which include spaces and letters. And you follow other users and you have a Twitter timeline. So as you scroll through, you see different people that you follow or things that you're interested in, and then that gauges your attention. You can click links. If you like the tweet, then you can retweet that post, and then it shows it to other people that follow you. And then it just grows and grows, and more people see what you're interested in, and you see what you're interested in. So some examples in the healthcare setting of things that have been tweeted and how it can be utilized in the health setting. On the left side of the screen, it shows that a patient was in the ER, wasn't getting any care, tweeted about it, the hospital saw it, and then took care of them. On the right side, it shows that their hospital is using Facebook and Twitter to help manage their diet and exercise, and it allows different communities. I know for a lot of our patients now, even within the last couple of years, specifically Dr. De Niro, a lot of his patients will have a VCD support group on Facebook or Twitter, and they can communicate with people throughout the world who have diseases that aren't very common, but they feel less alone by using social media to discuss their problems and how their treatments can be affected by using these.
but there's a balance. So the willingness to share information depends on trust. So 61% of consumers are likely to trust information posted by providers. So that's what this whole talk is about, is you getting us more involved in social media to help our patients. 61% are more likely to trust providers, whereas only 37% aren't really going to trust a drug company. But the most influential factor in people being involved on social media and engaging in these platforms is age, which is not surprising. So more than 80% of individuals from the ages of 18 to 24 would be likely to share their own health information through social media, and 90% would engage in health activities or trust information. So I'm going to say that again. So more than 80% of people will, and 90% of those would seek care based on what they would see on social media in that age range. Drastically different for individuals age 45 to 64, where less than half of those would share their information on social media, and more than that would engage in health activities based on what they see. So our goal was to characterize the content, sources, and overall trends of Bell's palsy posts on Twitter. We did this by utilizing Simpler. It's a healthcare social media analytics company, to create a data set of tweets that included the words Bell's palsy over a 3-year period. From 2018 to 2021, we excluded spam and non-English speaking accounts. And the picture on the right just kind of depicts the type of data that we get from Simpler, and a lot of, and then you use that, it's a ton of data, and then you have to break it down and analyze it. So the main results is from 2018 to 2021, there were 16,000 tweets relating to Bell's palsy. We broke those down into the general public versus the healthcare realm. So you can see who's more involved, the general public. Their tweet number drastically increased in 2020, and these are actual tweet numbers. People in healthcare weren't as engaged in this platform. And then we further broke that down into what are the tweets doing? How are they being utilized? So about 1,400 were healthcare based, which had more attached links and media. So that meaning you have a link that links to your office-based website, or a video of yourself talking about what you like to do in the OR. When you compare that to the general public, which had 14,000 tweets, less media, less links, it just has all the information right there in the tweet itself without having to go elsewhere to find more information. And this just charts break that down even more. The more interesting fact was you could see that there was a triple-fold increase in the tweets in 2020 amongst the general public when compared to the prior 2 years. Why? Why would that have happened? You can see how dramatic that was. And so when we dive further, this is why. So there was a lot of social media backlash against the COVID vaccine for saying that Bell's palsy was related or caused by the COVID vaccine. This is just a news story. And so to see that even further with our data, you can see here that in the healthcare group's tweets, vaccine was only listed one time in the number of occurrences. So this chart shows how many times vaccine came up in the tweet for healthcare-based groups. Whereas in the general public, the top words that were in their tweets were vaccine, Pfizer, COVID, and Moderna. Like all of those were the main things in their tweets. So this just shows that the healthcare tweets weren't discussing this. They weren't talking about it. Whereas in the general public, that's what they were concerned about, were these vaccines. Again, with the hashtag, same thing. So if you aren't familiar with a hashtag links to other comments based on that. So it's a way to group people together with a commonality term, and you can link through it that way. Again, in the healthcare groups, on the general public side, hashtag COVID-19 was a top 3 utilized term, and with healthcare, it wasn't in the top 3. So again, healthcare providers weren't really utilizing this platform to help educate patients, whereas the general public was using it dramatically, and it was affecting them getting the vaccine. So this is an example of how it could be poorly utilized. This is not a healthcare-based tweet. So this was shared over 10,000 times across all social media platforms with more than 300 retweets on Twitter. It was shared on December 10th, 2020. A reverse image search on Yandex showed that it actually came out on a YouTube channel from an Indonesian news outlet in January of 2020. And it was just about information on Bell's palsy. It had nothing to do with the COVID vaccine, but someone in the general public decided to use the image and affect people's healthcare decisions. And just to further prove this, Pfizer and biotech didn't announce the start of their clinical trials until after this picture was even posted in April. Again, it's shared by so many different people across all different languages. It was shared greater than 10,000 times, and people explaining that it's just not a real post, but it's not done by healthcare providers as well. So when we also looked at the sentiment of relating healthcare versus the general public in relation to Bell's palsy, healthcare people, we take care of people with Bell's palsy, so we have more of a positive outlook in our tweets, whereas the general public, based on these tweets that they see, had more of a negative outlook on Bell's palsy. This is one of the positive documentations of a physician. This is Dr. Kim. She is a facial plastic surgeon at OSU. And she posted that she was a facial nerve specialist and she had her vaccine today, just as an example of how you can utilize social media to your advantage for both patients and people that you aren't even taking care of at the time. So then there have been many studies that show that there is no causality between the vaccine and Bell's palsy development after getting it. And these have all been published, but no one really knows about them unless you're Dr. Oyer or Dr. Park. So this study just showed that there have been a 0.6% rate of facial paralysis after the mRNA vaccine. But there's been decades of vaccines that cause Bell's palsy, immune mediated or induced by viral reactivations, but there's been no studies that have been able to identify a higher risk of facial paralysis after this vaccine. So as of March of this year, over 320 million vaccines have been administered worldwide, but the reported rate of facial paralysis in this study is not higher than any other vaccine that's ever been given. The CDC also looked into this, which again, most of the general public don't know about, is they show that there is no difference between the rates of Bell's palsy development with the vaccine than that with the general public. But you don't see this on the social media platforms. So in conclusion, what we found is there's a trend of increasing tweets among the general public about Bell's palsy in 2020, which could be attributed to COVID-19 despite no causal relationship between the virus and Bell's palsy. And then why do we care? Again, just to drive this home, 42% of Americans search for health-related information on social media platforms. 45% of that will change their treatment based on what they see, despite who tweets it. So imagine the impact we could have had on global health if patients and other people around the world see these type of tweets rather than these, which are incorrect and false. So future work, we hope to do more of a user and tweet analysis to see what we can do to drive more healthcare-based tweets that are accurate to have a better outcome and dispersed more worldwide rather than the false tweets that we've seen. But currently, most healthcare professionals' posts tend to excuse self-promotion in favor of educational content. So that's why we want to delve into how we can get our tweets more widespread. The AAO does have its own Twitter account now. That's what you can see there. So as the use of social media for health information grows, our patients can benefit from the increased presence of our otolaryngologists on these platforms. And here at UVA, we are working to have a better social media platform. To my references, and I'd like to thank Dr. Wykamp and Dr. Oyer for your help with this project. Dr. Kuczynski and Dr. Dubrow are also going to help us moving forward with further analyses. Any questions?
How do you distinguish
Yeah, so the question was, how do you distinguish positive and negative? You mean the sentiment? Yeah, so it has to do, they look at all of the replies and the retweets and the simpler, it's the market, the data set company that we use that analyzes all the tweets from around the world. It's a computer-based system. And so on Twitter, I didn't want to go into how you use Twitter, but you can thumbs up, thumbs down different tweets. And so they can analyze the amount of thumbs up, thumbs down based on that. And that's how they get the sentiment. No. They take that into account as well, but that involves more of like analyzing the actual tweet content, which is what we're doing next. Thank you.
right, good morning, everyone. It's an honor being part of this group. Well done to those who've gone so far. Great for the opportunity to present. I'll be discussing machine learning and radiographic biomarkers in head and neck cancer. I'd like to start off by thanking Dr. Garneau, my mentor. It's been an honor and privilege getting involved in the work he's doing. Also, Dr. Fletcher from the School of Engineering, his graduate student, Jinzu Jin. The work they're doing is really impressive and it's been fun to get involved with. So I'd like to start by outlining my talk. We'll first discuss radiomics and machine learning deep neural networks at a 30,000 foot view. We'll talk about the capabilities of the technology and some of the clinical applications that have been previously studied. And then we'll explore various applications of machine learning to head and neck cancer. We'll discuss our own work creating a UVA algorithm and some of our early results validating our model. Then we'll finish by discussing our vision and future directions. So radiomics is an emerging field of imaging analysis capable of extracting large amounts of information from medical images that are unperceived by the human eye. By examining an image in great detail, an image can be converted into quantifiable values. Those values then can then be studied to look for patterns, texture features, physical properties, and neighboring relationships. So this is how it looks like with a CT. CT scan, as we know, is a large series of two-dimensional images or slices. Each slice is a mosaic of individual voxels. A voxel can be thought of as a three-dimensional pixel, and each voxel has its own attenuation value based on the intrinsic property of the tissue it represents. So in CT, think like Hounsfield units, and then that value becomes interpretable data to analyze with powerful algorithms to study in regions of interest, like a tumor. This is a schematic just showing publications dealing with radiomics over the last decade. So it's a very hot topic right now. Really quick, as you can imagine, the data derived from radiomics is extensive and vast. So I wanted to touch briefly on what machine learning and deep neural networks are. So machine learning is a subset of artificial intelligence that involves algorithms that have the ability to learn for themselves without being explicitly programmed. And then deep learning is a subset of machine learning that uses algorithms to interpret vast amounts of data, discover patterns and relationships, and make predictions based on that data. So here's what it looks like, a schematic of a deep neural network. In essence, you have an algorithm that you train by feeding both input and output data. The model runs through the data to identify patterns and relationships and look for ways that we got from point A to point B. It develops rules and patterns. You then take that trained model and you give it a new set of data, but only give it the input data, and you see how well it can use the same rules and patterns to predict the output for that data that you, the validation data. Quick baseball reference here. This is a picture, an infamous picture of the Houston Astros sign stealing scandal, where the teammates were banging on a trash can and giving him the sign whether a changeup was coming. The MLB hasn't really, they've kind of kept a lockdown on the technology they use. The big thing was that they use technology to do this. Here's a picture of prominent YouTuber, Mark Rober, who's got a great video out there that explains neural networks in really simple terms. And in the video, he goes through designing an algorithm to steal baseball signs. Then he goes to a little league field and steals the signs. And it's a cool video. All right, so one of the things about machine learning and deep neural networks, this technology has been around for about 10 years, and yet its clinical utility is still relatively limited. And one large critique is that the neural networks are somewhat uninterpretable sometimes. So it's like we have a Ferrari here. We see how powerful it is, it's fast, it functions well, but when we look under the hood, we don't really know what's going on. So with our models, as you see, the middle layers are called hidden layers, and it's this black box that has sparked interest with the computer scientists and Dr. Fletcher from the School of Engineering. So there's a really huge focus in the realm of AI right now, looking into making these models more interpretable, discovering what is in these hidden layers and making sense of them. So head and neck cancer provides an ideal clinical application for this because we have pre-treatment CT scans, large databases with good follow-up data, and we're able to take those CT scans and make all of that data is already garnered in digitized form and easily available for radiomics-based prognostic predictions. So what's been done so far, as you can imagine, this work is being done, in all realms of cancer and other fields in medicine. But in the head and neck, it's been limited. So in 2015, Duke et al. Out of Boston University investigated the use of texture analysis, looking with radiomics analysis to distinguish whether textural features could predict HPV status in patients. They ran their study in 40 patients with oropharyngeal squamous cell carcinoma and identified 3 textural features that could significantly distinguish HPV status, and concluded that radiomics and textural analysis could be used as an adjunct to P16 in identifying HPV status in squamous cell carcinoma. So I'd like to highlight some of the work that Dr. Garneau started at Case Western as it frames what we're doing here at UVA. So this is a really cool study, some figures here looking how they use radiomics and looking at head and neck cancer tumors, specifically oropharyngeal squamous cell carcinoma. So the objective of this study was to use radiomics to identify radiographic biomarkers in patients with oropharyngeal squamous cell carcinoma, specifically looking at whether radiomic features could predict HPV status. So they used the TCIA, which is it's the Cancer Imaging Archive, which is an open archive of de-identified cancer specific medical images and associated clinical data. They use radiation therapy plans available in this archive to measure both tumoral and peritumoral areas and did a radiomics analysis. This was previously described in both breast and lung cancer. So these are radiomic parameters and ROC curves that were designed to evaluate the model's ability to predict HPV status. So these are the curves run on both the training data set and then how it performed on the validation data set. And the area under the curve is used to show that the validation data set was able to, it showed a strong classifier. So they were able to identify 15 radiomic features, 4 intratumoral features, and then 11 peritumoral features that were heavily used by the algorithm to then predict HPV status. So taking a step back, we already have P16. Why would it be important to know about the HPV status from an image if we're doing biopsies on all these patients? But this is really kind of the first look into using radiographic images to identify the molecular signature of a tumor. And it has, really significant implications. So really fascinating stuff. Here at UVA, we've, Dr. Garneau, Dr. Fletcher have designed our own algorithm with the objective of identifying radiographic biomarkers in patients with head and neck cancer. Our vision is to create an algorithm that both looks at radiomics, like that study I just showed, and then also include comprehensive data that is readily available in Epic, like demographic data, risk factors, et cetera. We first plan to train the model in a similar way to the study that I just mentioned, and then develop our own database to validate that. We're looking at 3 specific endpoints: HPV status, extranodal extension, and the risk of developing distant metastasis. So what we've done so far, we've taken the same archive to create our both our training set and validation cohorts. We have looked at tumor size and aspect ratio to evaluate how well they're associated with the risk of developing distant metastasis. We chose these 2 features, tumor size and aspect ratio, as they're readily available, not overly sophisticated and interpretable. So you can think of tumor size, that's intuitive. That is just the volume based on, again, radiation therapy plans. And then aspect ratio is how a tumor changes, the shape of the tumor changes as you pan left to right through the image. So it's somewhat a surrogate for shape complexity, a little bit more complicated than that, but beyond the scope of this talk. So we calculate alignment scores, which are commonly used in deep learning to signify how heavily an algorithm relies on that feature to get the appropriate output. And then Kramer distance was calculated, which is a consistently used metric in deep learning, which tells us how well the machine is analyzing that metric correctly. So here's a schematic of our data. It's still preliminary, but this is really promising. So what we've done is it's showing that we have successfully developed an algorithm that is using this data appropriately. So we have on the left there random features of the image, and it is appropriately not weighting that heavily, whereas the both aspect ratio, and tumor size is being appropriately weighted throughout our model in classifying these patients into whether they have a risk of developing distant metastasis. So very promising data. And we have a lot of plans moving forward. Again, we plan on incorporating radiomics, demographics, and looking at various features, and even allowing the algorithm to identify features that are not clinically apparent to us now, specifically looking at these three outcomes. So in conclusion, machine learning has demonstrated the ability to identify radiographic biomarkers, which are objective, quantifiable parameters that are reflective of a tumor's molecular signature. Our homegrown algorithm has successfully identified tumor size and aspect ratio as features that classified patients based on the risk factor for developing distant metastasis. And our next steps are to further train and validate our neural network model with more comprehensive features based on patients treated here at UVA. And then eventually we hope to design prospective studies using our model. And we're very interested in also applying our algorithm and radiomics to cancers of unknown primary to identify whether we can pick things up that are not apparent to the naked eye with radiomics, and then parathyroid localization as well. Take any questions. Yeah.
You might have said this, but when looking at distant metastasis and risk for it, did you compare it to what we know the current risk now is from literature, and were they comparable?
So we're testing our algorithm on things that are clinically intuitive. You know, tumor size and risk of distant metastasis is, you know, clinically intuitive jump, and we're making sure the algorithm's appropriately using that output and identifying the way it should be allocated. So I don't know if that made a lot of sense, but right now we're still validating our model to make sure that it works, and then we're going to use it to predict. Yes. So the algorithms are proprietary. So we've developed our own algorithm here that is able to, so the data is not, that's just intrinsic in a CT scan, but the ability to interpret it and make and analyze it, those algorithms are proprietary. And I think, you know, it's beyond my understanding of how those are developed. But I think they're all similar. They're just, we had to use our own homegrown algorithm.
So this may turn out to be more of a comment than a question. I haven't actually gotten to the end of it in my head yet. But I noticed, you know, when you were talking about the data that are out there, and I think this is a very natural tendency to say, okay, you know, we let the machine do the learning, develop the model, and then we want to know what was the machine looking at. So what were the actual real factors that it was studying? How important is that actually, or can this just be a black box that gives us the right answer?
Yeah, it's a great question. That was my first question when learning about all this stuff. Like, why not just use the Ferrari instead of really looking under the hood? I think one phenomenon that is a little bit unintuitive, but you can overtrain a neural network to where it starts becoming less accurate. And in order to appropriately use it, we have to at least have some understanding of what it's looking at, so we can test it. You know, there's looking to feeding it false data to see if it is able to appropriately tease that out. And I think that overall, you want to have confidence that your model is looking at things that make intuitive sense and not just kind of gibberish or noise.
Thanks, Jeff. All right, last one for the first group, and then we'll take a quick break, is Dr. Saez. He is going to talk about an unsupervised analysis of type 1 laryngeal cleft phenotypes and outcomes in children who undergo diagnostic laryngoscopy for severe respiratory symptoms.
Good morning, everybody. This is great kind of to follow Jeff's talk and build on that theme of machine learning and what really is capable using those methods. So this is a slightly different method that I used. And by the end of this talk, I really hope to shed some light on the wide and varied world, which is type 1 laryngeal clefts. As practitioners, I believe this is something that we've all felt to some degree, because without some semblance of order within our schemas of diagnoses, we end up relying on our intuition, which isn't a bad thing, but it really probably shouldn't be the only thing that we rely on. And as such, we start hunting for these classification schemas. We look for ways to group similar patients together under the assumption that similar patients will respond to treatment in similar ways. We see this recently in the literature for CRS, asthma, otitis media. In general, it anatomy, laboratory, demographic, etc. However, to date, there has been no such hunt for classification schema for type 1 clefts in the literature, despite that they often present with a very varied clinical picture, despite their prevalence of around 6% in children who undergo laryngoscopy for recurrent wheeze and dysphagia. Despite management strategies which are varied in their risk and inconsistently applied even to equivalent patients. All of this kind of fueled the primary objective of this study, which is to determine significant type 1 cleft phenotypes through unsupervised cluster analysis. And as a secondary objective, to really assess clusters for correlations with their symptomatic and surgical outcomes. So unsupervised cluster analysis is a powerful tool in determining groupings and phenotypes when we don't know what the potential groups are, or in other words, when we're working with unlabeled data. This is mainly because it does not rely on a priori assumptions of the disease process, and it really invites into the mix the possibility of being surprised by the data, because in unsupervised methods, we include as many predictive variables as we have access to, and then we let the data tell a fuller story. Okay. So here's a 1,000-foot view of unsupervised machine learning that I performed. Let's say you have a disease state X. In our case, we had 42 potential predictive variables for these type 1 cleft patients. Now, all of these variables may be relevant and unique, but more than likely, some of them measure the same thing. And the thing is, we don't know that until we do a principal component analysis. That's when we really reduce these variables into key factors, okay? And once we know these factors, and once we know which variables kind of go together, then we can actually get scores, okay? And from these scores, we can create groupings, we can create these trees of patients, and then transform those groups into clusters. And off those clusters, we can start developing some hypotheses. We can start talking about disease outcome comparison and treatment allocation based on those clusters if they're clinically relevant. So we recruited patients through a retrospective chart review and screened 522 records over a period of 7 years. In total, there were 184 patients that met criteria for inclusion into the study. Of those 184 patients, a total of 69 underwent at least one surgical repair consisting of some combination of either injection augmentation or endoscopic repair. In total, this represents the data collected for this study with missing values highlighted in black. These values were usually missing because the cleft was diagnosed on a non-aerodigestive tract day. Bronchoalveolar lavage data was not collected for that patient. And so what we did is we conducted separate analyses, one for the whole group of patients, another for other smaller subsets that had less missing data to kind of validate the clustering between these different subsets of patients, okay? So from a 1,000-foot perspective, also, missing variables were imputed using chained equations. On each imputed data set, we conducted a factor analysis, we did the clustering, and we did discriminant analysis. This was repeated for each iteration, and it was also repeated for each subset to kind of validate the clustering amongst all these different, potential groups of patients, okay? So looking at the factor analysis, we started with 42 variables, remember? And we were able to reduce those to 17 factors that accounted for 68% of the variance in the sample, a value that is a good threshold for dimension reduction techniques. Multiple dendrograms were then created for each data subset, and we used a Ward's method, which is a fancy way of saying we basically wanted to reduce the within cluster variance. And this is the prototypical dendrogram that was created for each one of these subsets. And after looking at dozens and dozens of these, there emerged a pattern across the dendrograms that looked something like this, where there was one cluster that was always the largest, call that cluster 1, cluster 4, which was kind of on the side, smaller and very kind of distanced from the rest of them, and cluster 2 and 3 kind of worked their way out in the middle. Here, you can see a little more clearly how these cases separated out. And this is kind of looking at them in a 3D space. You know, each cluster is really color-coded by different dots, and the axes are different discriminant functions, okay? So in total, that kind of method was replicated 15 times on separate subsets of the data, and clustering based on these factors correctly classified 85.3% of cases on a leave one out analysis. So in other words, the cases reliably grouped together. And these were the clinical characteristics of each cluster, okay? So there was an upper airway obstruction cluster. This one was the largest. These patients had increased tonsil size, adenoid hypertrophy, a pre-op diagnosis, usually of sleep disordered breathing, increased BMI, and they also had the highest prevalence of lipid-laden macrophages. Next largest, there was what we'll call the GERD and airway reactivity cluster. These patients were younger. They had dysphagia, wheezing. They were more likely to tolerate more likely to be okay with thin liquids, and less likely to have severe comorbidities and glottic pathology. Next up, in PEG utilization and glottic pathology, to name a few. But of note, there were also many factors that were not significant in distinguishing between these patients. Of note, eosinophilia did not turn out to be significant. Whether or not there was bacteria or virus that grew out in their BAL fluid was not significant. Cleft type even, sex, concomitant laryngomalacia, or whether the patient had preoperative stridor. Looking at one of these, cleft type, right? You know, that we'd think that might be significant, but if you look at, you know, perhaps one of the reasons why it's not come out as significant variable comes down to the inter-rater reliability and the subtlety in making this diagnosis. And there ended up being a significant association between the type of cleft diagnosis and the physician performing the laryngoscopy, a finding that has been borne out in the literature surrounding the subtleness of it. Also, for those cases that ended up receiving an operation, there was a significant association between the physician performing the procedure and the type of intervention employed. So when we look at just the sheer proportions of cases that ended up undergoing at least a surgical repair at some point, the upper airway obstruction cluster here in the blue had the highest percentage at 51%, with the type 2 cluster being the lowest at 20%. You know, these differences were not significant on the chi-square testing, however. When controlling for synchronous procedures, such as tonsillectomy or supraglottoplasty, there was no association with increased rates of cleft repair and cluster assignment. That saying that this upper airway obstruction cluster just didn't undergo higher rates of repair simply because they were also getting a tonsillectomy at the same time. And it was like, why don't we just perform a supraglottoplasty or perform a cleft repair since we're doing a tonsillectomy? These were independent. We also looked at post-op composite scores of dysphagia, respiratory symptoms, and scaled intervention scores using multivariate analysis, and we factored based on the cluster assignment. There was no significant association on the multivariate test with a P of 0.1. So, but just for fun, I just looked at to look at the post-hoc analysis, understanding that this difference is not significant on the multivariate level. You can look at these graphs to get a sense for some of the trends, right? For example, the obstructive cluster here had the highest rates of intervention. And when looking at, how well they did from a respiratory standpoint, and this is 1 to 2 years after their day of diagnosis, they ended up having the best scores, so the lowest scores. They also had the lowest scores for dysphagia, so they were doing the best on that front as well. So what does all of this tell us? One, we know we can rely on these groupings. These initial phylum of patients are replicable. Also, the lack of a significant trend towards surgery for one group over the other, it may be a reflection of the retrospective nature of the study and the lack of real treatment standardization, or it may also be a sign that our prototypical script of what we think a child with a laryngeal cleft looks like symptomatically is lacking. Lacking because a not insignificant amount of the time we find unanticipated clefts in a child with EOE or with early onset asthma or with Down syndrome and dysphagia. And for these kids, the decision surrounding whether or not we intervene on the day of diagnosis is not a trivial one. So areas of future research are ripe. There's a need to develop a rational surgical approach for type 1 clefts and to develop better markers of aspiration. There is some evidence for lipid-laden macrophages. We saw that the obstructive cohort had the highest rates, especially given their increased rates of surgery. However, in general, we don't know. And